Well, it's Healthcare Unfiltered, and today is actually a special episode because we are talking about something rather unique and also something that I'm learning about. I was not. It's a topic that is completely, I would say, I wasn't fully familiar of it and of the impact with it, but I got to meet a wonderful gentleman, David Krissman, who is going to introduce himself in a little bit and what he's been doing over the past several years. And I promise you that this conversation will be fascinating, educational, and it's gonna probably leave you scratching your head. So, David, welcome to Healthcare Unfiltered. Appreciate you taking time of your schedule. And for context, I always want to make sure my listeners and viewers know that we're taping this in October 2023 because a lot of things sometimes happen between the time we tape and the time we air.
Right.
So who is David Krissman?
David Krissman grew up in Los Angeles, went to school in Seattle for college, came back to Los Angeles, worked in journalism, then went to film school, and then worked in Hollywood for about 10 years. I still do some work related to the video production and that type of storytelling. But as you said, I released a podcast documentary series at the late last year, beginning this year. And it's called The Great Social Experiment. And it's the story and lessons of America's only experiment with universal healthcare, which is kidney failure. So
we're going to talk about that. Don't get it all out yet. Not all out yet.
Okay.
I want to try to understand a little about your journalism career. Tell me about what were you writing about, what topics you covered, and how did you what was the experience like?
So it was mostly interviewing people for cover stories. Really anybody, really the range of people that I covered was just all across the board, from Hollywood celebrities to business people to doctors to lawyers. So it was a really good experience of being able to find a story out of anything, right? They would say, go interview this person. And sometimes you would just meet them and you'd be like, oh, well, I'm going to have to really work hard to figure out how I can shape this into a longer article. And
who did you work for at the time?
It's a defunct newspaper group, magazine group. It was called Baker Newspaper Group. And they did a bunch of city magazines and in-room hotel magazines. Very, I would say, different than the investigative type of work that you would hear in The Great Social Experiment. It was more about Hollywood and luxury and lifestyle and stuff that I really never even thought about before working there. Because as growing up in Los Angeles, I was just much more interested in sports and women and anything like that a teenage boy would care about. And then I started working for this magazine company based in Beverly Hills, and suddenly I had to know about Saks Fifth Avenue and Chanel,
of course,
and Cartier.
Yeah, well,
and I started getting a lot of gifts in the mail at work.
Oh,
yeah. Because if you're an editor of a magazine, everybody wants to send you their product. And so I get all these unsolicited.
Hopefully Cartier want to come on my podcast.
What?
Hopefully Cartier want to come on my podcast. That's what should happen, right? Because
I know
they'll send me a present.
Exactly.
So then you went to Hollywood. How did this happen? In Hollywood,
Yeah, that's a good question. So I had always had an interest in writing for film and TV. And so even, it started really when I was about 18 years old and I had no clue what I was doing, like none. I was writing in Microsoft Word, unformatted, and did it throughout college. And then an ex-girlfriend of mine, she bought me a screenwriting book like kind of screenwriting 101 for dummies. And I was like, oh, interesting. And then I bought software, and then I continued to do it and got some formal education in it from UCLA, and then got my master's degree in film production at Loyola Marymount University. But I would say throughout this journalism period, um, I was always writing before work. So sometimes I would get to Starbucks, which was down the street from the office where I worked, at like 5:45 in the morning. And then I would write before work, and then I'd go to work and do more writing there. And so, by the time I actually, even though I really didn't know how to use a camera for the most part when I started film school, I had a really good sense of storytelling and kind of some of those fundamental ingredients.
Yeah, I mean, a lot of this is about storytelling. I can't agree with you more. I mean, people like this, and I think they're going to learn a lot about telling the story about this. So you're doing your you're doing your work,
Yeah.
and then you stumble about something pertaining to kidney failure and dialysis that made you scratch your head and think differently.
Well, I
I'm trying to
think
find the link. How did this
if
happen?
I, so yeah, so if I'm being honest, when I was in my mid 20s, I would say, just as, I mean, suddenly I had, I found some success. I had, like, I was 25 years old. I had a manager, I had an agent, I had an entertainment lawyer. I remember being at the top of the MGM Towers in Century City going, oh my God. And, I was poured tea or coffee or whatever it was from, this beautiful china. And I thought, this is kind of incredible. But shortly after that, I came down with something that we still don't know what it is today. I got sick. Um, and it could have been, I think my best guess today is that it was from an acupuncturist who gave me, like a Chinese acupuncturist gave me some herbal teas to drink. And this was for something totally different, of course. But I don't think my body really took to it well. And I started to have a lot of problems to the point where I was debilitated for about a year and a half. And so um, I went through the healthcare system. I saw I started to see some of its pitfalls. And I started to, I appreciated what it was like to have something chronic.
How old
And
were you when this happened?
26.
You know,
26 years old.
as
Do you
26
remember
as
Do you remember Sidney Sheldon, the
yeah,
author? I
yeah.
had just gotten the rights to his life story, an option, which he
Wow.
gave to me for $1. And
Wow.
yeah, and I was working through that, and then I started to not feel well, and I was working full time, but it was pretty bad to the point that I was living with my folks at the time, and my dad would take me on a walk up the street and back, just small walk, just so I could get some exercise. Um, and so at that point, I started to really have an appreciation of what it was like to deal with something that was chronic.
So when you say chronic, I mean, you got sick, but you were assuming that you're going to get sick and get better. You did not think it's going to be a chronic thing.
Well, when months and months goes
Right,
by,
right. Yeah, I
and
mean,
you're
but
still not
initially,
really getting
yeah,
better,
yeah.
and
But
doctors can't tell you what's going on.
right.
The only symptom I ever had was my liver enzymes were up, not a tremendous amount, but they were up, um, as they were up enough to be flagged, right?
Right.
And they didn't
Right.
go down for over a year. And this is despite the fact that I never drank all that much or anything like that, right?
Did you ever get a diagnosis, an actual?
No, nothing. But after a year and a half, I was desperate, and a doctor wanted me to try a medication off label just as an experiment. And he was right. And it pretty much gave me my life back. I went to film school. I was able to pull, 18-hour days at points, made a bunch of films that I was proud of. And so I, unlike some of the people we're going to be talking about, and I'm sure some of your patients, was very, very, very lucky.
Well, we're
That
hoping that your future film is going to be Toxic Exposure. I'll send you the book, but I'll send it to you in a couple of
I
days.
hear it's very good.
Well, thank you. So this is interesting because at the age of 26, you're young, you're vigorous. Really, the last thing on your mind is to think you're going to get sick, and then you got sick, and you experienced healthcare. Then what happened that transitioned you to?
So I continued to write. I did well in film school, and I wrote. I just continued to write, and then at some point, I read an article in the New York Times about a kidney chain. And essentially what that is, well, let me back up a second. So in the early 2000s, they discovered that they could do paired exchanges with kidney transplants, meaning if you need a kidney and I need a kidney, and you have a willing donor that's incompatible and I have a willing donor that's incompatible, they will throw us into an algorithm and realize, oh, wait, I'm a match with your willing donor and you're a match with mine, and then we swap. And then I believe in 2005, a bright doctor who I actually know, who's at the University of Toledo, Dr. Michael Reese, came up with an idea, which was starting these transplants with an altruistic donor. Because in the previous example that I just gave you, it has to be done simultaneously, all 4 surgeries, right? The nephrectomy and the 2 transplants, right? And this is for fear that somebody will back out. But if you have somebody who is an altruistic donor that doesn't want anything in return, like your willing donor wanted something in return, which was you getting transplanted, and my willing donor only did it because I was going to get transplanted, right? If you started with somebody who's altruistic, then you have a situation where they can give to you, your willing donor can give to me, and my willing donor can pay it forward. And you create a chain, and the chain doesn't have to be done simultaneously. And so the article that I read was in the New York Times was about a chain of transplants that were, I believe, like 35 long, which means 70 surgeries all connected across the country, where they're flying kidneys from, LA to New York, or, New York to Florida. And I thought, oh my God. Well, the entertainer in me thought, oh my God, what could go wrong? Right. And so at first it started out as just just purely for entertainment, a compelling story. And I got a posse of doctors and experts to talk to me about the subject because it's not really easy to understand.
So let's try to explain it a little bit further. I just want to make sure my listeners and viewers understand it practically. So these are people who are altruistic donors. So they basically don't care who they give the kidneys to.
Correct.
So they're willing to have their kidney taken out from them, and they have no idea who's going to take it.
Perhaps
they know someone will. They know someone will.
They know somebody will. Perhaps they know who it is, but it's not like they came to the table knowing who that person was.
Yeah, because right? They may not be, maybe I want to give you my kidney, but we're not a match. So they take my kidney and give it to somebody else I've never met because I'm a match with that person, right? That's how it works. Okay.
Correct.
But it still have to be done around the same time. Like I still have to have the surgery and the kidney has to be flown right away at the same time.
Correct. Well, so once the nephrectomy happens where they take the kidney out, then that kidney obviously needs to be transplanted shortly after, right? But that doesn't mean that the next surgery has to be done, the next nephrectomy has to be done immediately. It could be done a week from then.
Right. Right.
Do you
Right.
do you get that? So you have the altruistic donor donates to somebody. The person who wanted to donate to that person can then donate to whoever, to whoever's next in line, but it doesn't have to be immediately.
Yeah, it could be like a week later or 5 days, depending.
Yeah, yeah.
Yeah.
So the article
Okay.
I read was over the course of months where
Okay.
this whole chain happened. And I just thought it was fascinating.
It is fascinating.
Yeah, it's very
Okay.
fascinating. And so I started to learn about it. And I got, like I said, people to help me really wrap my head around the topic and why this wasn't taking off the way it should in terms of every transplant center in the country enrolling patients in a registry.
So who was doing that? Like, because when you read about the article and you questioned why is not this being done with all transplant centers in the country, who was the transplant center who was coordinating all of
So
this?
yeah, so it's the National Kidney Registry,
Got it.
and they have been able to, I think they're doing about 1,000 transplants a year now. But in the early days, they struggled, as far as I know, because transplant centers were very hesitant to give up control, and perhaps some of them thought they would lose money. And so the script that I wrote became almost like a behind the scenes of the financial incentives of transplantation.
Got it. Okay.
And during this course of writing the script, I just became very, very knowledgeable about the topic, and I was able to meet donors and a lot of recipients. I started to join every Facebook group, which, by the way, has been a godsend for a lot of these patients, because they don't get a lot of information, unfortunately, in the medical system, and they have all these issues, whether they're transplanted or dialysis. And Facebook has allowed them, has allowed for these communities to pop up where you can ask your peers, oh, is this normal? What do I do in this circumstance or that circumstance? And so I started, becoming a member of all these Facebook groups, to the point where, and I started to post for research, etc., to the point where my friends were like, hey, are your kidneys okay? And I said, yeah, they're okay.
So
I'm
what was it
writing
like?
something.
Was it the entertainer in you that was fascinated by this, or was it the fact that you were sick and you were in the healthcare system? Like, what was the thing that triggered you? Because I can see
Right.
where your friends are coming from, right? Like, you don't have a kidney disease. It's not really something triggered you to become very vested in this and interested in this.
So at first, it was strictly the entertainment part of it. But then when you start to learn about the financial incentives in the system well before transplantation, and you talk to these patients who are very, very sick, it becomes personal, particularly if you
Yeah.
had my history of, I never had a life-threatening disease, even though I was tested for many of them. I never did. But they do, and they're debilitated. And when you realize that they're not getting the proper information about transplantation when they're on dialysis and why they're not, it became very, very personal to me. When you make friends who are on dialysis.
Yeah, I mean, you became intimate with the problem, and you got to meet a lot of people, and so it became very personal. So, what did you do next? I mean, and what did you want to try to resolve, or what was the problem that you're trying to tackle?
Well, one thing that I noticed is that it was something that not a lot of people were talking about. John Oliver did a really good episode, but he kind of scratched the surface. Um, the what I had found through this podcast documentary series is that at no point along the continuum of care does any provider, including transplant centers, have a financial incentive to get the most patients transplanted, even though it is light years better for the patient who's on dialysis. And it's more economic. So, just kind of like solar panels. You buy solar panels because you want to help the environment, but eventually you want to stop having a high electricity bill, right? So there's a financial incentive there. And eventually these solar panels start paying for themselves, right? But unlike solar panels, which may have a payback rate of, at least then it was like 7-10 years, maybe more, a transplant actually pays for itself in like 1.5 to 2 years. And this is something that the taxpayer pays for often. And so people were not getting the information. It was about how to proceed with transplant, how to go about trying to get evaluated, all of these things. And it was costing them their lives. And it's also a huge tax burden on the American taxpayer.
So is that when you launched your podcast series, and is that when you decide you build the website, The Great Social Experiment, and I want to urge all
So
viewers and listeners
originally,
to check it out.
I rather than waiting for $3 or $4 million for somebody to fund the film, which is actually a different story. The podcast series is more about getting on the list in the first place, and then what happens once you're on the list. But rather than wait, I had all this information pent up, and a lot of people are afraid to say it. A lot of patients are, because they don't want to upset their doctor. They don't want to upset their clinic. A lot of people live in remote areas where there's only one clinic. And whereas for me, I didn't care. I just, I don't have kidney disease. And I wanted to investigate this issue. And so I was originally going to write an article and just submit it for publishing in a magazine. And then I thought, well, that's just going to get buried in the archive of some publishing company. So I decided to produce a podcast series because at that point, I already had a pretty good skill set in filmmaking, editing, kind of a ninja in post-production.
Do you want to tell listeners and viewers what's your podcast series and how they can actually look into it?
Yeah, so it's at thegreatsocialexperiment.net.
What I mean, the goal of this, like whenever you launch something, you wanna go from point A to point B. One element is highlighting the problem, exposing the issue, and I want to make sure you articulate what is the problem you're trying to highlight and what are you trying to expose, and then what's point B that you would have wanted to see, and how far are we from that point that you're trying to accomplish.
So what I wanted to show, kidney care is very, very, very unique in the United States, and that it is really the only disease and medical condition that has a universal system. It's our only experiment in universal healthcare. So since 1972, the United States government has been covering the cost of this disease for patients who don't have private insurance. And so it's really the closest thing to a single payer we've had. And as a single payer universal system, you would expect it to be the pinnacle of what's possible in our larger healthcare system, right? Kind of like a role model. But what I found is that it suffers from the very, very same things in terms of quality of care, equity, and cost that our larger healthcare system suffers from. And if you understand how something that is fully funded and paid for can be can fall short, then it puts the rest of healthcare into perspective.
But what you're trying to propose, and let me make sure I get this right. One of the things you're suggesting is that because physicians make a lot of money from dialysis, there's a reverse incentive that they really don't want their patients to go into a transplant list because somehow they make a lot of money from dialysis. It's a big quote unquote accusation. You need to back yourself up by that.
Right.
Because it seems to me that it's, I think most physicians hopefully are recommending to patients what's best for them.
Right. I think it's a complicated problem. But yeah, so when you take a look at this wait list, so let's call the wait list access to quality care, right? Let's say if you get on the wait list, at least with this disease, you're not guaranteed an organ, but at least you have a fighting chance, right? So it's let's say that's access, right? For that to happen, you need to learn that transplant's even a thing, in which many patients don't even know. So imagine you're a patient on dialysis. Imagine you don't feel well and you crash into dialysis, meaning this has been asymptomatic for years, and all of a sudden you don't feel well, you get rushed to the hospital, your doctor says, you need to go on dialysis, otherwise you're going to die. And so in all likelihood, that doctor will refer you to a clinic. Now, what the patient doesn't know is that very, very often that doctor is referring you to a clinic for a very specific reason, because they have a financial vested interest in that clinic, right? So you have dialysis clinics which filter the blood of these patients. And these patients go in about 3 days a week, and they're there for about 3 to 4 hours at a time. It's a grueling process. And the clinics in the United States right now are owned by two for-profit corporations, DaVita Kidney Care and Fresenius Medical Care. And they make money for every person that is in one of their chairs, right? And they've made billions.
But there's nothing wrong with that, right? I mean, you're providing good care and you're making money for the care you're providing. I mean, surgeons operate on brain tumors and they make money.
Right. Absolutely. I totally agree. But there's caveats to this. These clinics, by Medicare's rules, are responsible for educating patients about transplant. And they and many other clinics, not just them, have done a very, 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 very lousy job doing that. Here's a pamphlet. Say you've been educated about transplant, right? If they're educated at all. And look, DaVita and Kidney Care, they're very fragmented organizations. So you could be at a really good clinic where they try to get as many patients transplanted as possible. But overall, the business model is, we want to keep our chairs as busy as possible. And if somebody gets a transplant, they don't need dialysis anymore. And so that's a lost client, right?
It is a lost client, of course, but I think we don't know whether this patient is not being referred for transplant because they don't qualify for transplant or because of the reverse incentive.
Absolutely.
Right.
Yeah. Let me get to that. Now, I don't know why. I'm assuming maybe that Medicare thought it was easier, but you would think it would be the doctor's responsibility. And the doctor still has a moral obligation to refer patients to transplant, right? And but they're not spending the time either to do that. And when I say they, there's plenty of really, really good nephrologists who do the right thing. But when you looked at the totality of the people that are actually making it to transplant, sometimes patients over the years who eventually do get a transplant aren't told about this for years on end, right? When it should be the first thing they are told, perhaps once they're stable, right? And the way Medicare pays these doctors is on a capitated form of payment, where they get paid per patient for everybody that is dialyzed under their care, right? So the more patients that you're overseeing, the more money you get from the government. And in the United States, there are two types of nephrologists in general. There are transplant nephrologists, which are maybe like 10% of all nephrologists. And then there are regular nephrologists. And the biggest bulk of their money comes from dialysis, whereas the transplant nephrologist, usually works for the transplant center, and they oversee patients who are going to undergo and after transplantation.
Okay.
So there is a financial disincentive for doctors as well. And then when you combine the fact that they often have basically joint ventures with these dialysis clinics, they're not only making money from the government, meaning the doctors, but they're also making money on the back end from the clinics themselves. Now, you brought up a good question, which is, how do we know how many should be on the wait list as compared to, how do you know? Because it could be that everybody who should be on the wait list is on the wait list and everybody else is just not medically eligible. So
Right.
this is something that I looked at, of course. And I went to Emory University and I talked to their director of dialysis. And I asked her a question. I said, how right now we have, maybe 14, 15% of patients who are on dialysis are on the wait list, right? So that's about 90,000 out of 600,000. To put that in perspective, there are more people on dialysis than the whole population of Wyoming.
Okay.
And I said, how many should be on the list?
Mm-hmm.
And she said, oh, probably another 40% of those that remain should be on the list. So she's talking about more than 50% as opposed to 15%. Now, of course, you could make now this woman is like a national.
Did you ask her why are they not?
For the very reasons we're talking about.
She acknowledged that. She said,
oh yeah, you can hear her talk about it. Yeah. And so the transplant centers are not at fault too, and we can get into that. But then I thought, well, she's a nationally renowned doctor, really, really bright, really works hard to improve equity where she can. But that's just one doctor. You're an oncologist, right?
yes.
You could argue that you might have a different opinion over something that many other doctors, have in oncology. So I got an interview with the former chief medical officer of DaVita, who used to be at UCLA, and he served as the chief medical officer of the largest dialysis corporation in the country. And I asked him this very same question. And he said at least half of those people on dialysis should be on the list. So, That's two.
So that is pretty big. I
Yeah.
mean, there are patients who are on dialysis, receiving dialysis that we think should be on the list. Now, obviously, being on the list does not guarantee you're going to get a transplant because you have to have a donor and everything. But certainly, not being on the list assures that you are not going to get a transplant because you're not on the list.
Not only that, it assures that you're going to die a lot sooner for
Yeah,
the most part,
yeah,
right? The average life expectancy in this country for someone on dialysis is about 4 years. Now, a lot of these people are very comorbid, right? They have a lot of other problems too.
yeah. Sure, sure, sure.
Um, but it's a
Um,
very, very, very grueling procedure. Um,
So,
yeah,
so clearly there are patients who should be on the list who are not on the list, and there's an ongoing hypothesis that some of the reason that pertain to that is the financial gain from keeping patients on dialysis.
they've done studies too.
Right.
So one of the wonderful things about having a Medicare paid for healthcare system is that they collect data on a lot of things. And so you've had researchers who've gone through and compared, for example, the rates of referrals um, for transplant at for-profits and nonprofit clinics. There's a couple of examples that I go into in the podcast, and they all have to do with money. And yeah,
So I mean, there you can make an argument that this actually could exist outside of nephrology as well, right? I mean, I think that it's not far-fetched to assume that there are other disciplines where the type of medical care that's being delivered could be affected by financial incentives.
absolutely. I
Have
mean,
you have you thought
I think our
about looking
whole
at yeah, have you thought about looking at outside of nephrology and
so
where
that
other
the podcast itself actually covers that. Um, the whole last episode puts this experiment in universal healthcare into perspective in the larger system. And it talks about how we ended up with so many people on dialysis, even in the first place. And it goes back into history as to why we have the healthcare system we do.
Yeah, there's a lot. That's another podcast about the healthcare system. I actually take a
Right.
podcast back in the day called Healthcare in the United States, a Hot Mess. I still think we're better off than a lot of other countries, despite all of these. Um,
Well,
but
let me
certainly,
ask you a question, respectfully, of course. Which other countries do you think we're better off from?
well, depends on the metrics that you actually look at. I mean, I think that the issue here with the U.S. is there are many patients who don't have access. So I think the access is a big deal.
Mm-hmm.
I think if access is equal amongst everybody, if let's say assume that everybody can access healthcare, we do have faster ability to undergo imaging. We have faster access to novel therapies. Lots of the research that's being done in various disciplines coming from the US. The problem with the US, I believe, is that drugs are very expensive. And they continue to be more expensive, and not everybody has access to healthcare. So, just because the drug is there doesn't mean you're going to access to it.
Right.
But I think if I'm sick, I'd rather be sick here than being sick in another country, just maybe because I'm used to the system, maybe because I have access to healthcare. But if I didn't have access to healthcare, obviously being sick somewhere else might be easier because then you can go to any emergency room and get treated easily. But I have colleagues who have practiced outside of the US, in Canada and elsewhere, where things are easy to get to if you are in a really dire emergency.
Mm-hmm.
But for routine clinical care, it's really very difficult and very challenging. And that's like from sources that are just my colleagues who are in these regions. That
So
doesn't
if you
really that doesn't answer the bigger question that we're talking about.
Well, the bigger question. So I would tend to disagree, and I'll tell you why. We First of all, I don't think we have quick access to healthcare. Um, I you see people on strike right now. The nurses who are on strike from Kaiser because they're being overworked. There's a huge shortage just for my own primary care. I had to wait over a month for a primary care
Oh, no,
appointment.
no, and longer. I was trying to get one of my friends referral to an allergist and one to primary care. And I was given March 2024. I didn't mean I didn't mean the wait times. The wait times are terrible. I'm assuming that you have the access. The wait
I
time,
mean, I do have access, but I still had to wait. Um,
right? The wait
yeah,
times are disaster, and it's actually gotten worse since COVID for
it's
sure.
gotten a whole
Yeah,
lot worse.
for sure.
But if you actually take a look at the major metrics across our peer countries when it comes to chronic disease, when it comes to chronic disease like diabetes, um, when it comes to being overweight with obesity, when it comes to suicides, when it comes to life expectancy, all the when it comes to access, we do the worst in almost every single category. And it's not because we go to the doctor more. We actually don't go to the doctor nearly as much as some populations, for example, France or Germany or whatever. For the wait to see a specialist, I believe France and Germany are faster than we are. Um, and every single major metric. Now, look, if you compare us to Russia or you compare us to India, yeah, we're going to do
Yeah,
well.
I think these metrics are also, I mean, I've seen these metrics, I've seen a lot of these things, and some of them are not always like some of them are accurate, and some of them are, it's very difficult to look at. Is there room for improvement? Absolutely. I don't think it's very difficult. I mean, that's a completely different topic to compare healthcare systems across countries. I don't believe there's a perfect healthcare system anywhere. I would just say we can't make the perfect the enemy of good. Are people, are we better than Germany and Germany better than us? It's really tough to tell. I mean, I think that, you talk to German people, they prefer to come to the US. You talk to US people, they think Germany is better. Um, but
But I mean, they do have these metrics, and Germany does do better.
But
I
to me,
mean,
the
I guess
metric,
it depends on if you
to
trust the
me, to
metrics.
me, the metrics is talking to people. I mean, I think I always feel like you gotta talk to people, whether they are patients or doctors, and get like firsthand knowledge by asking them what their experience is. Um, and what they have been, because I've always thought, for example, Canada is a great system, and then I talk to physicians in Canada and to patients in Canada, and they're extremely unhappy. So I don't really care what metrics the government of Canada is going to push out. I'm just talking about my own
Right.
but I don't think we have a perfect healthcare system. I think we have a lot of issues in our healthcare system. I tend to believe that the cost of healthcare in the US is one of the biggest challenging things, because you go to the emergency room here and you see how much you pay versus if you go to the emergency room in Japan and you see how much you pay. But I guess my question is,
Mhm.
when you look at what you have done with the Great Social Experiment, what you have learned and what you have done, what are the solutions that you can do it for this, but also more importantly, solutions that you can scale up in general across the
Right.
healthcare ecosystem? Because I think your observations were very, very astute and very interesting. I just personally don't think they are only for kidney. I think they're likely disseminated across many
Right.
disciplines. So what can we do?
Right. And I think you kind of hit the nail on the head when you said there is no perfect healthcare system. By its very nature, healthcare is something that you that you do when you're not feeling well, right? And there's really, I mean, they do quantify certain statistics like what we were talking about. But in general, the fact is that by its very nature, you're never going to be able to save everybody's life. But I think what the great social experiment teaches us is that it's not necessarily who is paying, but how you pay, right? So in this experiment that has funded kidney care, the government has been the payer, right? And the government doesn't care whether you're black or you're white, whether you're rich or you're poor. It makes no difference to them when it comes to transplantation. They get the bill and they pay for it, right? But it's the metrics by which we hold our healthcare system accountable, which are important. So if you are not going to pay for people to get to transplant, people are not going to get to transplant. If you're going to incentivize a healthcare system, this healthcare system, to keep people on dialysis, then they're going to remain on dialysis. If you and you see that in our larger system too. As you know, doctor, we don't put very much into primary care in this country, right? And we don't pay for access. And so a lot of people end up getting sick and get chronic diseases when these things could have been caught earlier. And one of those is kidney care, right? The fact is that about at least half of patients, I think I said earlier, they crash into dialysis. Now, just like cholesterol causing heart disease, kidney disease and chronic kidney disease, before it becomes too late, it is largely asymptomatic. So people go for years and years and years feeling just fine. And then they wake up one morning and they're like, oh my God, I don't feel good. And something like this could have been caught. If doctors were given the time, not just the incentive. I think there's a lot of good kidney doctors out there, but they're so rushed. And everybody in our system is more or less paid by volume, right? So you have a bunch of primary care practitioners who are going, in to see this patient, then they go to see that patient, they go see, and the whole incentive is to see as many people as possible. The whole incentive for hospitals is to have the hospitals packed, because then they make more money. If you're a hospital, you want every single one of your beds full.
Right.
Whereas in an ideal situation, from a policy perspective, you would want every single bed empty. And so we don't incentivize patients to see doctors because they can't afford it. And we don't incentivize doctors to do a good job with patients because they're rushed and they don't have the time. I'm sure you've experienced either yourself or colleagues who do.
It's a real problem.
Right.
I'm not disputing the problem, and
right.
I lived it. I'm struggling in finding solutions.
The solution is to literally revamp our whole healthcare system. What you want to do, and look, I'm not on. There are plenty of intellectuals that are looking at this, and we can look at what other countries are doing and try to pick the best parts of what we see in other countries that are doing better than we are. We do have our own unique problems, and I'm not saying that we should take Canada's model or Great Britain's model or Germany's model. Germany doesn't have a single payer system. They have a multi-payer system, but those payers, those insurance groups, they're actually nonprofit, like legit.
Yeah.
And their doctors, there's a cap for how much their doctors can earn.
Well, it's tough to have that in the US. I mean, it's a capitalistic society, and I think
they're capitalists too.
Well, but I mean, I think if you are a
Do you have
busy
a
doc,
Mercedes or BMW?
no, if you're a busy doctor, though, right? If you're a
Yeah,
busy doctor and you're seeing whatever, if I'm seeing 25 patients a day and the other is seeing
correct.
15 patients a day, it's a little bit not fair, if you would think. If you're seeing patients on the weekends, the other is not. I mean, I think it's all not volume should not be the only metric, should be quality of care, not just the volume of
Right.
care.
It's the outcomes that you want to
Right. But
incentivize.
I think if somebody is working harder than somebody else, it seems to me it's only fair that they earn more.
100%. No, nobody is saying
In every other discipline, it's the case, right?
right, but every other, not in every other discipline,
Well, if you
right?
work hard, hopefully you should be rewarded.
So yeah, but that is not the case in every other discipline. That's not the case, and I'm not comparing the amount of education here, but that's not the case with police officers. That's not the case with teachers. You could argue, and I would argue, that education is a universal right, right? And we have universal education up until through high school, right? Where it's funded. I think what we have to do is not the nurses, because the nurses have been on the forefront of trying to get the money out of healthcare, but the doctors. The doctors need to have a powwow, I guess you could say, and really ask themselves whether they think healthcare is a human right. Because if we do think that, there will be a limit to the amount a doctor can make. But right now, it wouldn't be fair to the doctor. Right now, a doctor graduates $200,000 to $300,000 in debt from medical school and residency and fellowships. I can't even imagine how hard you've worked, right? So somebody in your position who's hundreds of thousands of dollars in debt, has their own family, wants to send their kids to school, wants to take vacations. How can you tell that person that you're just going to chop their salary in half? But
I mean,
if we change the culture and we take the money out of it, not just there, but like if I were, one of the first things that I would do to improve the healthcare system would be to send every doctor like you to medical school for free. So, and then maybe they can work and give back once they start practicing for 5 years, 10 years or something like that. And they're not going to still get paid a good salary. I would struggle to think that any doctor in the UK and Germany is living a poor life, right? But I know some doctors who are my close friends. One of them sees majority Medicaid patients and has struggled to afford a place to live, like to buy a home, the American dream. And the other one has a couple of Teslas, right? And it's
yeah, I
not
mean,
that
there is disparities in everything. There's no question. But I don't think it's. I've seen the debates on healthcare since I've come to this country 32 years ago, and I think it's going to continue forever, and I don't think it's going to change because it's just not. I think there's a lot of things that are happening in terms of the healthcare system in the US that I'm not really sure is going to really change the entire system. Now you can refine it and make some small changes, hopefully to the better. I just don't know if you can really change everything because, like you said earlier, there's a lot of reverse incentives to everyone. I mean, I could make an argument. I mean, look at the hospital system, right?
Yeah.
Why is a Tylenol if I take it in the hospital is $35 a pill of Tylenol while I can get an entire bottle from Costco for $10? So there's just so many things we can talk about in terms of the
100%.
issues pertaining to the healthcare. But I guess I want to try to finish up, David, with what is next for you? Like, I mean, you're very vested in the healthcare. Clearly, you're well positioned. You're educated about it, and you're very interested in that particular sphere. As a filmmaker, as a journalist, you have this ability to probably reach a lot of audience not only about your ideas, but about more of an investigative journalism type of thing, using all of the capabilities that you have. So what's next for David Krissman in that healthcare debacle that we talked about?
So eventually I would like to do another series on the larger healthcare system that looks into a lot of the things that you mentioned.
Netflix. No, I actually
Netflix,
say
right?
I actually mentioned that because I think people consume information differently. Like, you know,
Yeah,
I like listening to podcasts when I'm driving. I can't listen to them if I'm
sure. Yeah,
not
me too.
driving, for example, but I could sit down and watch a couple of episodes of Netflix or a documentary in the evening versus listening.
Right.
I presume you're looking at various avenues, no?
Yeah. Well, right now, actually, I'm actually talking to multiple transplant centers about doing a pilot program that involves storytelling and community mobilization. Now, the one thing that we didn't touch upon in kidney care is that if you have a living donor, you don't need to wait. In fact, you can avoid dialysis and being put on the wait list completely. Every person has two kidneys, and studies have shown that you can live a normal life with just one. In fact, one out of every whatever 700 or 800 people are born with just one kidney, and a lot of them don't even know it. The problem is that once these patients hit dialysis, if they don't have somebody who's willing to donate to them, and that tends to be a good percentage of them, they don't have the energy and mental health to do this for themselves. And so one of the things I did after releasing the podcast series is I did my own internal trial. And I worked with a group of 3 patients. And the process was essentially create media for these patients and then organize their closest family and friends to disseminate that media, to basically tell their story. So right now, out of the two out of the 3 patients, we've had successful campaigns for. The third one, his name is Jim Morgan. He lives in New York, and he's on dialysis. And so my colleague Jen and I basically took him into this program, and then we educated his closest family and friends about why he needs a living donor, what will likely happen if he doesn't have a living donor. And when you educate your closest family and friends about that, it becomes real, right? And then, you know, we produced a media, we created a website for him that's on the Great Social Experiment, which has a bunch of free resources for patients already. And so far, since May, he's had about 162 people step forward and fill out the form to look into possibly donating, which is a lot.
That's amazing. That is the power of social media, the internet, and interconnectivity.
It's information. It's about getting the people the information and giving them tools to get that information out. And his surgeon has never seen anything like this. And so right now what we're doing, it's something that can be scaled up. And so we're talking to transplant centers across the country about doing pilot programs, something that really hasn't been done before. You know, this education media production, it's essentially, it's very, very unique to healthcare, because in healthcare, we just assume, you have a problem, you go to the hospital and they fix it. And this is one of those unique circumstances where they can't do something for you unless you have that donor, right? So it's taking a solution that's not medical and applying it to a medical problem. And it really hasn't been done before. So if you are a transplant surgeon or a transplant nephrologist or a donor coordinator, please call me, reach out on my website.
I like what you mentioned, actually, that this is a non-medical intervention being applied into a medical problem, and it works. And we have examples of that, like, sometimes just simply nutrition or whatever it is. I mean, non-medical intervention can work.
Yeah.
Well, David Krissman, thank you so much. The great social experiment with kidney transplants. I appreciate you taking the time with me today.
I really appreciate the invitation. I really enjoyed speaking with you.